thank you for taking a break with us. And so in the context of how we talk about breastfeeding, we truly do recognize that breastfeeding is not only an individual choice, but it's really a part of creating systems and supports to make breastfeeding the easy choice for everyone. And so we focus on work that's happening at these bottom layers of the pyramid. So we really don't have answers for questions about latch and support and that kind of stuff. So when we're talking about breastfeeding continuity of care, we've been doing many webinars. This is the third webinar of a series of 4. And so right now we're talking about why community clinical linkages in particular matter in the context of breastfeeding. We will be having another webinar on Wednesday, July 31st, and we'll be talking more about community-to-community linkages at that point. So final slide for me, and then we'll be turning it over to Haruni. In the context of this work that we're doing with CDC, this year we're giving a lot of focus on breastfeeding continuity of care and thinking about creating a blueprint. And we are still seeking organizations and individuals who want to be a part of that really big conversation. And so if you're interested in working on a blueprint for breastfeeding continuity of care, you can certainly reach out to us at breastfeeding@nacho.org to kind of follow up with us. And I want to turn it over to Haruni.
Good afternoon, everyone. So I was charged with the mission to make the case for a well-known public health concept, community clinic linkages, and applicable to breastfeeding support. So let's get started and see what the literature says. So what are these community clinic linkages, or CCLs? Anyways, CDC's definition states that CCLs are connections between the community and clinical sector to improve population health. They can be applied to all public health areas and focus on the unique contribution that each sector brings, because community and healthcare partners share the common goal of improving the health of people and communities. So this image illustrates the conceptual framework of linkages. You see 3 elements: patients, clinic, and community resources. The linkage is in the central area of this Venn diagram, where all 3 circles intersect. So the central area represents the combined interactive influences of all 3 elements and their relationship with each other. Then the larger bridge, so this navy blue icon is a bridge, represents partnerships that are established between the clinical and community sectors. The smaller bridge at the center represents the processes of placing actual patients on that existing bridge to connect them with community resources. So for the sake of today's webinar, we're considering public health as community services. So it's the bridge of clinical healthcare and public health services. One key thing to consider when looking at this picture is that the intrapersonal aspects of each relationship influences the linkage effectiveness. For example, a clinic efforts to connect patient with community resources depends on patient's perception and trust of the community organization providing the services, the culture appropriateness of resources, and the effective communication and trust between patient and the referring clinician. So the goals of community clinic linkages are connecting healthcare and community activities to promote continuity of care and facilitate engagement in a specific health behavior. It helps identify gaps in services and assist with creating systems that make the healthy behavior easy to be adopted. It improves access to care, patient gets more multi-sector help in changing unhealthy behaviors, and enhance capacity of both sectors to carry out their mission, because clinicians get help in offering services that they cannot provide themselves, and vice versa, which maximizes the collective impact to improve population health. So these effective collaborations offer a double win scenario for all participating organizations, but especially for the public. And there's growing evidence which documents that clinical conditions such as high blood pressure, diabetes, can be improved with community clinical linkages through improvements in healthy eating, physical activity, and diabetes self-management. So how can these CCLs be put into action? First, it's critical to identify existing gaps in needed services and fill those gaps by using strengths of each partner. It often involves participating in coalitions, alliances, also developing referral mechanisms. We'll talk more about referral systems. Training on teams and partner staff. This also helps standardize health messages so families hear the same message from different providers in different settings. And one of the most popular CCL example is programs working with community health workers to improve delivery of health services. They're also known as advocates, outreach workers, promotores, patient navigators. They are frontline workers that are trusted members and have a great understanding of a community. For example, within WIC, these navigators work with families and bridge gaps between WIC and other preventive services, including prenatal care, dental services, behavioral health. They also reinforce educational messages given by the healthcare team. So here, best practices for CCL includes developing referral systems. And then there's different types of referrals. The bidirectional, which is the ideal one, it considers both information going from the healthcare system to the referred community program and the information returning to the originator of the referral. Ideally, the bidirectional referral system is integrated with an electronic health record that facilitates this feedback. This e-referral system can also provide baseline reports on number of referrals, number of services received, and other metrics, so linkages, impact can actually be evaluated. And then formal referrals, usually involving modifying these EHRs, EMRs, to prompt a physician to refer to applicable programs. EHR inputs are a natural part of the workflow for many healthcare providers. So these systems have potential for referral tracking and monitoring and reduce the burden of new work processes. However, it takes time and can be very costly. And then the informal referrals incorporate referral mechanisms without the use of EHRs, and they are often used when minimal resources are available. As you see later, for breastfeeding continuity of care, the idea is not just to ensure referrals are in place, but to actually confirm that families successfully receive the referred services. Just looking at number of referrals tells us that one component of the linkage might be working, but if there is a caseload of 300 breastfeeding moms and only 25 receive referrals, and of those 25, only 10 are giving services, then this is not really continuity of care. So there's levels of CCL. There's the spectrum there. Networking is the most informal level of the partnerships. Contacts are usually like person to person rather than organization to organization. But just because it's informal doesn't mean unimportant. It's always helpful to have a contact person through whom you can get information, and also when you're trying to reach out to organization to work with. And then going further, there's coordination and cooperation. So here, partners identify ways of working together for a common purpose. Coordination can help address problems of fragmentation, overlap, and duplication in services. And then going up at the level of collaboration, this is enhancing each other's capacity. At this level, each partner works to help the other to become better at what they do. And at the top, integration. Then you have fully integrated funding and programs. So CCL, or any partnership really, can involve different levels of formality and commitment. So these levels of partnership may be appropriate in different circumstances. And there are the three T factors that influences this. It's time available, trusting each other, and turf based on different values and readiness for power sharing. So here's the barriers, and there's the time and trust again, and then finances, right? We know that time is money. So that is one of our main recommendations here. If you are working on a grant proposal, for example, make sure to always budget time for partnering. Building relationships and building trust take time. So have a partnership goal and a plan to build it. Funding usually is definitely an important enabling factor in forming specific partnerships that will collaborate in certain activities. However, it's very important to state that funding should not be the main reason you partner. Actually, from what we see here across nature projects, having those pre-existing relationships between clinic and community partners is one of the key facilitators for program success and for starting a new grant program right away. Of course, external funding further solidifies these linkages, but having even informal partnerships in place is key for when the opportunity associated with funding arises, relationships are already there. So other barriers include organization policies, leadership support. This includes commitment of staff who could oversee these relationships and very often provide in-kind support. So now let's get to the specifics of breastfeeding community clinical linkages. You see there, there's another poll about the Surgeon General call to action to support breastfeeding. It is actually recommending the community clinic linkages. So please respond. So it may seem obvious to link organizations that share similar breastfeeding goals within the same community, but hospitals, clinicians, and community organizations often provide services with little interaction with each other. So breastfeeding CCLs help to ensure that families have easy access to appropriate level of lactation providers that enable parents to start and continue breastfeeding. So you're probably familiar with this breastfeeding socio-ecologic model. This image is also a useful tool for looking at the landscape of key clinical and community partner linkages that need to work together. So breastfeeding community clinic linkages is a critical part of continuity of care. They're sustainable relationships between clinical and community sectors that effectively meet the unique needs of new parents. Most mothers want to breastfeed but may stop early due to the lack of ongoing support. So CCLs play an essential role in ensuring that referrals and access to community programs are consistent, collaborative, and seamless and timeless for families. CCL strategies should address the full spectrum of lactation support in order to provide transitions of care that are coordinated and fully supportive of families throughout their breastfeeding journey. So look what happens when who falls through the cracks when these linkages are not in place during the most critical period of breastfeeding challenges. The moms, right? New families. A very known guidance for CCL in breastfeeding are Step 3 and 10 of the Baby Friendly Hospital Initiative. I remember attending ILCA Lactation Conference in 2016, and the World Health Organization, the technical officer, Lawrence Burmer-Straw, who actually led the updates of these 10 steps, he said steps 3 and 10 is a whole different animal and needing like their own separate package. So why is that? Why is it so hard? It's different because the other steps were clearly articulated in form of procedures that were self-explanatory. It was more about creating internal continuity of care. For example, have a written policy, train staff, skin to skin after birth, no pacifiers. That's very clear. But then steps 3 and 10 are hard because it requires that staff step outside of the doors, outside of their comfort zone, and engage with resources outside of their locus of control. So it required a completely different set of skills than the technical breastfeeding management skills. Steps 3 and 10 are hard, but those steps have the potential to significantly impact maternal breastfeeding decisions and breastfeeding duration rates. Findings from a systematic review shows that Step 10 appears to be key for long-term sustainability of the short-term breastfeeding gains obtained as a result of the baby-friendly efforts. So the updates of Step 10 focus on coordination of post-discharge care, and it focuses on responsibilities of the facility to work to enhance community support. So each mother should be linked to a lactation support for continued and consistent care. Step 10 requires a clear understanding of where those resources are in the community and the specific steps needed to coordinate referrals. All this, like we said, takes time, establishing relationships, especially in historically marginalized communities where there may be limited resources available. In the hospital, they may know some IBCLCs in private practice, for example, outpatient, right, that works business hours. But these referrals will not work for families who cannot pay for services and have to go back to work within 3 weeks, and then they cannot take a day off just to go seek support, right? So finding out about community breastfeeding resources and telling moms to go there seems easy enough, right? But the warm handoff, a critical step for linkage in establishing continuity of care, can be difficult for all the reasons we discussed earlier. So warm handoff typically means that one member of the healthcare team introduces another member to the patient, explaining why they can better address a specific issue and emphasizing the other member's competence. In CCL, a warm handoff occurs between healthcare team from and to community partner team. Not necessarily in person, but keeping the aspects of continuity and consistency and predictability. It's like families leave the hospital with a set lactation appointment 24 to 48 hours post-discharge. Warm handoffs engage families and serve as safety check. So research demonstrates that reliable and effective communication is essential for safety and improved clinical outcomes. So for breastfeeding transfer of care, warm handoff does not happen often. Actually, it's not even widely used in overall pediatric hospital discharge care either. This lack of standards undermine the quality of pediatric care and adversely affect the health of children after they leave the hospital. So in the downloadable resources there's a tool detailing how to do an effective warm handoff, which including designing workflows, training staff, making families aware of the reason for the handoff. So we just talked about hospital and community linkage, but now we're going to talk about the linkage between providers and lactation providers, like healthcare providers and lactation providers in the community. So across the prenatal to postpartum continuum, many clinicians have contacts with mothers and infants, and each interaction presents an opportunity for breastfeeding support. Both AAP and ACOG advocate for their members to be at the forefront of providing support, breastfeeding support. But breastfeeding is a dyadic behavior, but in the United States, the care is typically separated from mother and infant. So this study in the Breastfeeding Medicine Journal talks about healthcare providers' perspective providing breastfeeding care across the continuum. The results show that the overarching theme was discontinuity in breastfeeding care. There are no captain of the ship coordinating this care transitions. And the reasons included lack of time, lack of skills, inconsistent messages, and low communication across stages of care. Providers were unsure whether their help was effective and whether it required follow-up. Also, OBs typically do not see women again until 6 weeks, and pediatrics felt that their visits were too infrequent to support breastfeeding effectively. So this critical period was missed when women encountered most of the difficulties. Prenatal providers relied on prenatal class instructors and nurses in the hospitals, and pediatricians and hospital nurses relied on inpatient lactation consultants, who in turn relied on pediatric offices. So pediatricians felt that prior providers should have done more prenatally and in the hospital. Each type of provider relied on others because of constraints with the healthcare system structure, as well as their own limited skills in breastfeeding care and beliefs about their role in providing breastfeeding care. Other studies also show providers' unconscious bias to actively support breastfeeding for families of color and bridging them to culturally appropriate resources in the community in the postpartum period. But there are some solutions on the way. There's AAP have this training to increase availability of medical training and engage physicians to promote continuity of care. And then New York 10 Steps to a breastfeeding-friendly provider practice, guides providers to foster relationships with local breastfeeding networks, establish formal referral systems, and encourage implementation of a seamless, coordinated transition of care. And here, again, the CCL spectrum now for breastfeeding. So networking, like you attend a Breastfeeding Coalition meeting. Then coordinating, you compile a breastfeeding resource guide in the community. And then collaborating, you may set up a bidirectional referral system using both partner structures and so on. Here are some examples of NATO previous grantees working with hospitals. So there's cross-training, leveraging texting programs, training of staff in the hospital and health department, creation of breastfeeding committee. So other examples of community clinic linkages in breastfeeding are breastfeeding coalitions. Coalitions usually have good understanding of community resources and have the key players at meetings from both clinical and community side. So for anyone trying to establish this linkage, engaging your local or state coalition is a first step to take. Another example are the breastfeeding-friendly pharmacies. There's a Well Babies, a Walgreens, which offer breastfeeding support at the pharmacy. They also engage pharmacists, who often are the most accessible medication expert for breastfeeding women. Wood County in Wisconsin, through a community clinic linkage grant from CDC, worked with a pharmacy and developed the breastfeeding-friendly pharmacy toolkit that was actually adopted by the Pharmacy Society of Wisconsin. And finally, there's linkages with home visiting programs. Home visitors are uniquely positioned to support breastfeeding since they are likely to see families frequently during critical windows, like 3 to 7 days postpartum, where breastfeeding problems peak and where families fall through the crack. So finally, to summarize, these are the 7 effective strategies for implementing community clinic linkages, and here they were applied to breastfeeding. So learn about your resources and your key maternal and child health partners in the community and at the hospitals, identify gaps in services, negotiate and agree upon the purpose for the linkage. Know which structures to use to implement your linkage activity. For example, referrals. Can you use a e-referral system? Can you establish a MOU for warm handoff? Aim for continuously coordinate the linkage even with no funding, and grow the linkage with sustainability in mind, because it will help with future activities. And finally, evaluate the linkage, obtaining feedback from providers and family on current referral processes will help improve the referral and the linkage. So that concludes the background session of this webinar. And I will now turn to Rosemary Bonacorso from Monroe County, who was a nature grantee in the past. And she implemented one of my favorite projects, partnering with healthcare providers in their community.
Thank you very much. So good afternoon, everyone. My name is Rose Bonacorso. I'm the breastfeeding coordinator for Monroe County Department of Health WIC Breastfeeding Peer Counselor Program. And I want to tell my story about linking and enhancing peer counselor services to hospitals and providers. Now, unfortunately, I'm not attached to the site today, so I'm going to have someone click for me. And I'll have you click to the next slide for me, please. So first of all, a little bit about who we are. We're a peer counseling program offering breastfeeding education and support to WIC participants in Rochester, New York, and throughout Monroe County. We partner with area hospitals, clinical providers in OB and pediatric settings to provide continuity of care at home and within the community. And we have been very fortunate to have funds available to us from multiple grants to enable us to extend our reach through the establishment of lactation services in settings that were not previously open to us. I'll have you click. So the question is, why is it beneficial to work with hospital and medical providers? That was the question we had. And in 2014, the breastfeeding initiation rate for our agency was 69.5%. And we were thrilled because this was an increase for us. We were close to 70%. But yet, at 6 months, our duration rate was 8.6% among Monroe County WIC clients. Why was our duration rate so bad? Click. Whoops. Okay. Well, you need to know a few things first. In Rochester, New York, we have one baby-friendly hospital. That's a plus. All right, we all know milk supply is not established during the hospital stay, but within the first 3 to 4 weeks postpartum. We also know breastfeeding support should start prenatally and continue beyond hospital discharge. And peer support referrals can increase breastfeeding rates. And those referrals can also increase the linkages among providers, hospitals, and the community. So it's a win for everyone. We were fortunate because we partnered with the Community Partnership for Breastfeeding Promotion and Support grant through the University of Rochester and the National Institute of Health. This grant helped lay the groundwork for supporting families overcoming early challenges. Next slide. The other fortunate thing is that we live in New York. We're part of New York State, and the New York State Department of Health developed the 10 Steps to a Breastfeeding-Friendly Practice Implementation Guide. And you can see the link there at the bottom of the screen for more information on the specifics. So within this implementation guide, you have 10 steps. And 5 of those steps refer to, in their implementation strategies, referring all potentially income-eligible women and their infants to the Special Supplemental Nutrition Program for Women, Infants, and Children, commonly known as WIC, and a lot less words. You know, as early in the prenatal and postpartum period as possible to maximize breastfeeding peer counselor support. So here, I can't see your screen, but if someone would click, you're going to see a couple of the steps highlight and show up. Step 5 is the prenatal period. We know that's important because that's when the information needs to be given to the mom, and we hook her into some breastfeeding peer counselor support. We've got step 6, which refer to women, you know, postpartum as soon as possible if they aren't already tied into a peer counselor program in WIC. And even if they are, we know they don't always ask for help, send a referral again for that help to help establish milk supply. Step 8 is an important step because when moms are separated from their infants, duration depends on them being able to maintain lactation. So in the instance of going back to work, going back to school, pumping, this is important information. WIC can help. Step 9, identify your local breastfeeding support network. So if the offices and the providers are aware of what support is out there and there's a network of support, fostering the collaborative working relationships and referral systems to get the help moms need. And then step 10, which really ties into the whole rest of the breastfeeding journey, providing comprehensive breastfeeding assistance and advice for mothers. So that's the long-term management. So we had a few things going for us. Next slide. The other option that we were fortunate to have were funds available to leverage to help extend the type of work we wanted to be involved in and partner with the community and tighten up those linkages. So the first grant source was WIC itself. WIC has a known strong interest in promoting breastfeeding and the peer counselor program. The second funding source that we've been involved with for 10 plus years through 2 5-year rounds is the University of Rochester NIH Community Partnership for Breastfeeding Promotion and Support Grant. We were also fortunate to be selected as a grantee for the NACCHO grant, Reducing Disparities in Breastfeeding Through Peer and Professional Support. And the newest granting source that we've been, part of is the New York State Department of Health Creating Breastfeeding Friendly Communities. This is a 5-year grant. We're already a couple years in. And I want to go to the next slide to explain how all these grants overlap and produce results that complement each other. So now for this slide, I'll need someone to do some clicking for me as I talk about each section because I can't see what's happening online, unfortunately. So the WIC Breastfeeding Peer Counselor Program, if you click that, you see an arrow, University of Rochester NIH Community Partnership for Breastfeeding Support. Click again and you'll see the results of what came about because of our partnership and was put into place. We have peer counselors from WIC. They're trained through Loving Support training. We had a database developed through the U of R for charting purposes. We established rounds in 4 area hospitals. They developed a referral system for hospitals and providers to use to send client information to WIC so we could get them hooked into WIC with a peer counselor. And if they were already hooked into WIC, that just reinforced the connection, that no one would fall through the holes. We became involved in the Breastfeeding Coalition. Some community initiatives were introduced. We always have technical assistance as a WIC agency from our New York State Department regional office, always there to assist us and answer questions. And we had technical assistance from the U of R researchers to help develop things. So the next click will show, and click again, you'll see what WIC benefited from our partnership with NACCHO. The peer counselors had an increase present in provider offices because we had funding to send them there. With the presence in the offices, there was increased breastfeeding education opportunities that took place. The provider referrals to the peer counselor program meant earlier enrollment in WIC and increased breastfeeding educational opportunities. I'll have you click again. And this arrow between NACCHO and the University of Rochester. Click again and you'll see that breastfeeding drop-in groups, which were originally developed through the NIH University of Rochester grant, increased from 2 to 5 a month at different locations, hospital, an OB office, libraries, churches. We were able to, with NACCHO funding, expand into OB centering pregnancy groups, 5 locations. So how perfect is that? You get them during their pregnancy to let them know about WIC, to let them know about support, to teach them about breastfeeding and answer their concerns. OB and pediatric office visits within the waiting room to get referrals and just answer questions and promote breastfeeding in general happened. And we increased our outreach activities for breastfeeding promotion. And on one of the other slides, I'll show you one of the creative, innovative ways we were able to do that because NACCHO gave us the funding and the freedom to develop these activities. The next arrow, if someone could click, will show that between the University of Rochester and the New York State Creating Breastfeeding Friendly Communities grant, baby cafes came in. The baby cafes replaced our drop-in groups. So our NACCHO funding ended. We still had some funding to do drop-ins, but not as many. But where some of them were established, we replaced them because we already had that partnership done with baby cafes, now funded through New York State. They're set up in a hospital and 2 OB practices. Peer counselors assist with the baby cafes. Click again, and we've come full circle, and you can see that creating breastfeeding-friendly communities in WIC. The peer counselors are connecting families to WIC through the baby cafes. They're continuing to support outside the WIC clinic. PCs are working along with the lactation staff and maintaining that connection with provider offices. Breastfeeding-friendly designation for the provider offices ties into the peer counselor support, and we've come full circle. Click to the next slide. Don't know if I set my timer. I hope I'm not going over. Someone please.
2 minutes and a half.
Oh, all right, I'll step on the gas here. Here's our hospital partners, okay. 4 area hospitals we go to, 2 health systems. Click. Because we did the hospital rounds and were established there, the provider partners, both OB and pediatric, who are associated with the healthcare systems we round in, were more accepting to have us come in and be part of their efforts to become breastfeeding friendly. So pediatric, centering pregnancy, and you'll see our standees there. Those are our life-size cutouts who rotated through the different offices. Click. Breastfeeding drop-in groups. I think I spent a little time explaining how those were set up and have transitioned to cafes within the healthcare systems we're rounding in. Click. Here's a baby cafe. Peer counselors work in there, the 2 healthcare systems at the bottom of the flyer, partnering and sharing, helping the community. Next slide. Keys in setting up working relationships with providers and hospitals. I think Harumi kind of hit on these, but identifying your stakeholders, finding your common goal, having the seamless service and same messages, communication between referrals and visits. These are things you can offer. Establishing relationships with consistent visits, standard office time and hospital rounds are an example of that. Develop your MOU, Memorandum of Understanding, or a description of your expected scope of work in each setting. Am I over? Mutually agreed upon, and create standard operating procedures. Here are 2 examples. I'll run through them very quickly. There's a role and a scope there for peer counselors and the hospital that they go in. So that was mutually agreed upon, and a referral form. This is an example of what was developed to do referrals from offices, hospitals. It's very multi-purpose. And I'll have you click one more time. And okay, I want to thank everyone for listening to me remotely and all the partners who have helped make our program what it is. Thank you very much for listening.
Thank you so much, Rosemary. We really appreciate you taking the opportunity to present for our webinar participants. I really want to point out very explicitly the importance of not just connecting with hospital systems, which we're going to hear about from our other presenters, but really about connecting with providers in particular. Because when we're thinking about connecting to community, it's the providers who are working in the community spaces with families, the OBs, and the peds, who have the most probably significant impact over the long term, because we only have a hospital stay for a few days, right? And it's important that the hospital system support us, but it's also really important that we know that our providers are supportive of us. And so working within the medical practice sounds like an excellent idea, and thank you for sharing that with us. Our next presenter is going to be Valencia Moore. Valencia is coming to us from Parkland Health and Hospital System in Texas, and we actually learned about Valencia through our partner, through her partner, who sent in some information from the Lactation Care Center. So you all may recall, if you've worked with us before or listened to our webinars, that we have been collecting information about continuity of care and how it exists in this field. And so the Lactation Care Center actually sent in this information about how they are working with Parkland Hospital. We think it's an excellent project. You might see more about the Lactation Care Center if we do an issue brief or or a blog post about that. But right now, we're going to turn it over to Valencia so she can tell us about the work that she does.
Hello, I'm Valencia Moore, and I am the lactation consultant supervisor at Parkland Hospital. We are going to talk about a little bit about Parkland and about our collaboration with WIC. So the title of my slides are Promoting Positive Health Outcomes for Mothers and Infants Through Collaboration, Teamwork, Supporting the 10 Steps to Successful Breastfeeding. Why do we collaborate? Why do we partner together? Why do we form networks? And the answer is because it takes a village. It takes teamwork to make the dream work. So here is a photo of me and my family, and I did that for two reasons. One, because I'm a mom, and secondly, because I am African American. And when you think about health equity, health equality, social determinants of health, those things that we know are not equal and that we don't even have the same access to health care. But what we do know is that breastfeeding works no matter what race. At the end of the day, when a woman has a baby, we all become mothers, regardless of our socioeconomic status, regardless of our racial status or ethnic status. And so we know that if we can promote breastfeeding, that the benefits for breastfeeding will develop healthy moms, healthy babies, and healthy families. So Parkland's mission and vision is that we are dedicated to the health and well-being of individuals and communities entrusted to our care. And by our actions, we will define the standards of excellence for public academic health systems through compassion, skill, teamwork, and evidence-based care. I am so excited to announce that Parkland just celebrated this month 125 years of giving care to our community. And I have to give us a hand clap for that. You will see here in this slide that we started with a very old building back in the 1800s. And we have moved from that building to the one that was built in the 60s, which is featured here, until the one that we're currently in right now, which we moved into in 2015. Parkland sees more than 1 million patients each year. And you can look at our racial divide here. At least 82, probably more like 85% is Hispanic, 12% is Black, and 3% is non-Hispanic, white, or other. I am happy to say that we have 11 prenatal clinics. One of them is a MFM clinic, which is maternal fetal medicine for those high-risk moms. But we have 10 that are located out in the community. We want to go and care for our patients where they live, where they play, where they actually take care of their day-to-day activities. And so 95% of our patients go to our clinics. And so they are truly our patients. We're not getting them from offices that we don't know what is being taught or what type of care is being given. It is Parkland out in the community, and they come back here to this hospital and deliver their babies. If you look at our insurance breakdown, 95% of our patients are Medicaid. 3.4% are self-pay, and 1.6% are insurance. Currently, our deliveries are greater than 12,000. At one point, Parkland was up to 16,000 deliveries a year. So we deliver a lot of babies. On average, we have about 34, 35 babies delivered a day. At one point, we had 50. And so it can get pretty busy here. These are pictures of our new hospital and a map of our clinics that are located out in the community. I'm proud to say that we are here. We looked forward for this new hospital for so long. And so it is a 17-story building with 862 single patient rooms. What I do want to point out with this building, and you can see it almost looks like little Legos that are stacked on top of each other, but there is a tower that is specific to women's health, and this is where all the care is given for our NICUs, the labor and delivery, our mother-baby units, is all in one tower, and that is the gold tower of this hospital. The other tower is called the blue tower, and that's where we have other diseases and illnesses that are cared for. What we want to do is to encourage the moms while they're in the Gold Tower to breastfeed, so that hopefully we can prevent them from going to the Blue Tower later on. These are pictures of some of our WIC peer counselors. We love them to death. They are a part of us. I will say that our WIC peer counselor here in the hospital has been ongoing for several years, since the 90s, I believe. And so it was way before I began in this position, but we have worked with them for such a long time. They have just become a part of who we are. They have helped us tremendously in our Texas 10-step certification or designation that we have for the hospital, and they are also helping us with our baby-friendly designation. We have been on the baby-friendly journey for a long time, and they have been very supportive. Bridging the gap, the need for PCs or peer counselors. How does it benefit the hospital? First of all, when you bring peer counselors in and mommies see patients who look like them that have been through some of the same situations that they've been in, you know it makes a difference not only when you're compassionate for someone, but when you have actually walked in their shoes. It makes a big difference and gives you a different perspective. And so it increases patient satisfaction to have peer counselors in the hospitals. It increases the breastfeeding discharge rates. We know that we do have a very high initiation rate, and discharge breastfeeding rates are something to be improved, but we have their help, we have their support, and we're happy that they're here. Bringing PCs in also helps support the Healthy People 2020 goals and supports the 10 steps to successful breastfeeding. So how do you determine your need for PCs? How many WIC eligible clients do you have? For us, like I said, we have 95% Medicaid patients. And so if you qualify for Medicaid, you qualify for WIC. What is the current breastfeeding rate at discharge? What's your initiation rate? What's your exclusivity rate? And again, what are those disparities? How can we bridge that gap? What type of support is currently in place already? Right now we do have IBCLC lactation consultants here in the hospital, but there was a time when we did not. The department that I work in is Women and Family Education, but there were times when they weren't certified, and they knew that the help was needed, and so there were nurses who would go out and help moms with breastfeeding and educate on breastfeeding. But I am proud to say that we have 24 lactation consultants on staff here at Parkland Hospital, and the number of deliveries per year. So some of our partnerships that we've had with WIC, some of these are no longer in place, but I am proud to announce them. Maybe it's something that you can get in your hospital or with your WIC clinic. Maybe you can initiate some of these programs at a local hospital. So one is the Clinical Lactation Practicum. That is a program where people who are interested in becoming lactation consultants or even just learning more about breastfeeding can take this course, and it is partnered with WIC and one of the local hospitals, Parkland being one of them, and they can get 18 hours of education. It is part didactic and part observation in the hospital with hands-on lactation skills from the lactation consultant. I am sad to say that we no longer have this Peer Dad program, but at one point we had Peer Dad who would come into the hospital and they would teach parent classes in our NICU, and we did an annual Father's Day event, and they were very involved in that, where they would teach these new dads on new baby care and how they can support the mom with breastfeeding and just with day-to-day activities. How can the dad be involved? I'm hoping that one day that program will return. We also have the Hospital Peer Counselor Program. We had a Best Fed parent representative. She was very instrumental in telling us the things that, you know, when you're here and you're the healthcare provider, you may not see. But she gave us a parent perspective on the things that were taking place with our new moms. We also had the Texas Breastfeeding Learning Collaborative, Cohort C, which we were a part of, and we had a parent representative for that came from WIC. Also, our prenatal breastfeeding classes that's being taking place right now in our clinic and on our our antepartum floor here in the hospital. They have also helped us with the Baby Friendly Hospital Initiative Collaborative Workshop. That's where WIC has partnered with Methodist Hospital and Parkland, and we have started these workshops so that we can give part of the 5 hours that's needed for educating staff for Baby Friendly. And then they also train our medical providers. All of our pediatricians, medical students, and some family health practitioners will go to WIC and receive training. This is a picture of some of our lactation consultants here at Parkland Hospital and some that are with WIC. These are some fairly old pictures. I believe they were from a couple of years ago. So the staff has grown, which I'm happy to say, but we love them. They are here for us and we're there for them. This is a community resource that is given out at several different hospitals. We use this here to encourage the moms to go for help when they need it. I am proud to say that we do have our own newborn follow-up and lactation clinic that is staffed by a pediatric nurse practitioner and an IBCLC lactation consultant. And we will use this resource. First, we bring them back into our clinic, but then we will also use the Lactation Care Center where the moms can go and get further help if they need it. So we used to have a baby cafe, but they have changed all of our centers into the Lactation Care Center. And so if you look at this handout, you see that we have 3 different locations here. And they're located throughout the city in different areas. So a mom needing help can pretty much go to the center that's closest to where she lives. Again, these are just some of the photos from the Lactation Care Center. This is the referral form that we use. We will refer moms to WIC. First of all, our peer counselors come in and they will register moms for WIC if they are not registered. And if they are registered and still need help, we can fill this form out and tell them what issues the moms are having and send them over to the Lactation Care Center. One thing that I didn't mention with the previous form was that WIC will help moms regardless of her income, regardless of how much money she makes, if she can be a WIC client or not a WIC client. And again, bottom line is that we are all moms once we have a baby, and breastfeeding needs to be supported. And so the state of Texas knows that and has given grant money to the Lactation Care Center so that they're able to help any mom regardless of income. The second sheet on this page is a pump proxy. It is a form that was put in place so that we could help to expedite the visit once they go to the WIC Care Center, Lactation Care Center. And so we use this form so that we can say that they've been taught and then a dad or a grandmother or someone else can go and pick up the pump that the mom may need. Here is that same referral sheet. You can see how many referrals have been made, 4,258 just from 2017 to 2018. And 44% of the referrals come from Parkland. Again, this is another screenshot here of how many referrals are made to the Lactation Care Center monthly. And so it's averaging about 150 visits or 150 referrals that we give each month. This is education that we did with WIC and one of our clinics because moms believe that they don't have milk. So this was on colostrum specifically so that we can educate moms about colostrum. This was a little survey that was given to them, and it worked out really well. The moms were able to do this as a pre-test and as a post-test. And again, like I said, we are on our baby-friendly journey. We will have our baby-friendly on-site assessment on June 24th and 25th, so you guys be in prayer with us. But these are some of the forms that were used. You can even see here at the data on the baby-friendly journey update, say at 2017. We weren't ready to go then, but we are now. So be prayerful with us. Again, what's next is prenatal education that we have formed through WIC, that we work with them to form a flip chart. And there are 7 topics that were needed, and these are some of the topics that were needed by Baby Friendly. So again, there are 10 steps to successful breastfeeding. You don't have to see the whole staircase. Just take the first step. Thank you.
Valencia, thank you so very much for sharing with us. That was a really, really eye-opening presentation, and to really get an idea of the big volume that Parkland is kind of dealing with on a daily and yearly basis. And I wanted to point out something that's really important, and I think was critical, that no matter the income of the mom, every mom is a mom and every mom deserves support. And you said that that funding comes from the state of Texas. And so I would like to point out to everyone that that funding, from what we understand from talking to Chrissy and you, is that that funding comes from Title V. And every state gets Title V dollars. Title V dollars serves families and communities when it's a resource of last support. And so every state has an opportunity to choose what are going to be their core objectives, or things that they want to work on in terms of maternal-child health, maternal-child-adolescent health. And I think that 92% of states chose breastfeeding as one of the core things that they wanted to work on. So that's always something important for every state and every community to think about, is linking to Title V for more resources. Now, our next presenters are coming from the great state of Mississippi, and we're really happy to have Mississippi here. And we're going to be hearing from Kimberly Ramsey and Tawanda Hurt. And they work with Mississippi State WIC, and they're going to tell us a little bit about how, as a WIC agency from the community side, how they are able to push forward a partnership with birthing facilities. So I'm going to turn it over to you.
Good afternoon. Thank you so much for this opportunity. As she stated, I'm Kimberly Dixon Ramsey. I'm the director of the WIC breastfeeding program here in Mississippi. And today I have the pleasure of presenting information on how we were able to build partnerships with local hospitals using the Memorandum of Understanding process, also referred to as an MOU. First, I want to take a moment to give a brief overview of the Mississippi WIC breastfeeding program. Even though the WIC program provides infant formula support to families, we actively promote breastfeeding as the optimal choice in infant feeding. Our program provides peer counseling services so that moms have access to hands-on support and encouragement, which is particularly important in the early days of breastfeeding. We also offer home visiting services to mothers who may have challenges with coming into the WIC clinic. Mississippi WIC also provides breastfeeding aids and breast pumps to moms who may be returning to work or school, or to those who may have some breastfeeding challenges. We also provide educational materials and classes, as well as referrals to breastfeeding support services within the community. Mississippi had a series of events surrounding breastfeeding that created the momentum to establish MOU partnerships. In 2014, the Boston Medical Center received funding to increase breastfeeding rates, reduce disparities, and improve maternity care practices in Mississippi through the Mississippi Communities and Hospitals Advancing Maternity Practices Project, otherwise known as Mississippi CHAMPS. This support goes to provide technical assistance to 32 Mississippi hospitals as they work toward achieving the baby-friendly designation. With this initiative, we have the majority of our hospitals on the pathway to becoming baby-friendly. In November of 2014, the Mississippi Perinatal Quality Collaborative was launched. MSPQC is a statewide partnership that aims to promote evidence-based quality improvement initiatives at the hospital and community level to improve birth outcomes across Mississippi. MSPQC relies on collaborative, data-driven projects to address specific drivers of maternal and neonatal morbidity and mortality. And so as the Baby-Friendly Hospital Initiative became a hot topic across the nation, Mississippi had one hospital who took the challenge to become the first to achieve the designation in the state. and that was Forest General Hospital in Hattiesburg. They were designated in December of 2015. In 2016, a baby cafe was formed in the Mississippi Delta as a community resource and support program for breastfeeding mothers. This resource is available to all moms and extends the peer counseling support model to mothers who may not qualify for the WIC program. Then in 2018, we were able to bring a certified lactation counselor training to the state of Mississippi through partnerships with several organizations. And so with this program, hospital staff, WIC staff, and community breastfeeding advocates were able to attend a week-long training and sit for the exam with no out-of-pocket expense. With this initiative, we gained over 200 newly trained lactation professionals to assist breastfeeding families in the state. And so with this momentum and buy-in, the Mississippi WIC program was able to draft an MOU to further extend WIC's ability to provide breastfeeding education and support statewide. With the help of the MSDH legal department and our state health officer, the Mississippi WIC program drafted a letter to the CEOs of the delivering hospitals across the state. We also developed a proposed MOU, which was attached with the cover letter. We did a mass mail out to the 41 delivering hospitals across the state in November of 2017. Upon receipt of the MOU, the hospitals were asked to pick their termination date for the agreement. The effective date was default to the date of the signature. The hospitals would consult with their legal departments to ensure that they were within their organization's guidelines. The CEO or a designee signed the agreement and returned to us for signature from our state health officer. From this point, the agreement was considered fully executed, and a copy would be returned to the hospital for their records. There were some cases where the signature process was reversed, particularly if the hospital's legal department requested changes to our proposed MOU. As with anything, there were some challenges with getting the MOU signed. Because the MOUs were addressed to the CEO, many of them went unanswered simply because of the competing demands of getting things through at that level of the organization. So in those cases, WIC staff would seek to find a breastfeeding champion. Those would be particularly like our labor and delivery nurses or directors of nursing who would help us get some movement behind the agreement. There were some opportunities for me to go in and talk with hospital staff at their meetings to present information. And I also gained some traction with getting some of them signed by speaking at other convenings and meetings in the state in which hospital staff were in attendance. Also, with the help of CHAMPS and their site visits, they were able to help us to promote the importance of joining this MOU initiative during their site visits. And so, the Baby Friendly Hospital Initiative MOU, the goal of the partnership was to allow MSDH WIC breastfeeding staff to support implementation of the evidence-based Baby Friendly Hospital Initiative at Mississippi hospitals. The WIC program, we have a leverage of staff, and we wanted to leverage that resource because we have breastfeeding peer counselors and regional breastfeeding coordinators placed throughout the state. And so that's something that's very unique to our program. And so with this MOU, we were seeking to establish formal partnership agreements with the delivering hospitals throughout Mississippi. And we were also supporting the designation process by WIC staff assisting hospitals with providing support for steps 3 and 10. And so as of to date, since November of 2017, we've had 22 of the 41 delivering hospitals across the state to join us in this MOU initiative. I want to take a moment to look at the roles and responsibilities that were outlined within the cover letter and within the MOU. From the MSDH WIC program, we were asking to participate as members of the hospital's task force meetings. We wanted to prepare WIC mothers prenatally for positive maternity care practices, provide direct patient care for WIC mothers experiencing issues at post-discharge. We were offering to provide prenatal or breastfeeding classes, and also we were offering assistance with post-discharge support groups. What we were asking for from the delivering hospitals was to provide our WIC lactation professionals with information about when the task force meetings would take place, and we wanted to work collaboratively with WIC lactation professionals regarding the hospital's prenatal and postnatal breastfeeding needs. And we also asked that they refer prenatal and postpartum families to the WIC program. This slide is a sample of the CEO letter and the proposed MOU that was mailed. Our CEO letter gives background information on the impact of breastfeeding on health outcomes. It gives an overview of the Baby Friendly Hospital Initiative, and it talks about the proposed partnership with MSDH WIC and outlines some of the activities in which we could support their organization. Within the MOU, we covered roles and responsibilities from both parties, effective dates and termination dates of the agreement, and we also covered legal issues such as relationship, liability, HIPAA and confidentiality, and publicity. And so now that the MOU is fully executed, we begin work on establishing the partnership. And so what we would do is have an initial meeting with staff, and this was a get-to-know-you sort of meeting to find out what was going on in their hospitals and what needs they have for their breastfeeding education, promotion, and support. We would then follow those up with those initial meetings with more strategic planning meetings to determine what activities and classes we were going to implement and how we could best work those into their current patient flow. Once implemented, we evaluate the effectiveness of the classes and activities and discuss how we can expand upon what we were already doing. The task force meetings really provide us with a continuous flow in the partnership as we follow them through their journey through the Baby Friendly Hospital Initiative pathway, and we're able to adjust our support as needed. For step 3, we assist with prenatal education. And so because of this partnership, we've had some very interesting results in how far-reaching it has become. Because of the partnership with hospitals and our participation in task force meetings, a couple of OB doctors that deliver out of our partnering hospitals have opened their doors to us with an opportunity to provide breastfeeding classes to their maternity patients during office visits. So these classes not only cover breastfeeding, but other important infant feeding strategies such as skin-to-skin contact and rooming in. So to ensure that we are sending a cohesive message statewide, we're using the Ready, Set, Baby class curriculum. Our clients and also our breastfeeding peer counselors really enjoy using that curriculum because it dives deeper into the breastfeeding relationship. This education also prepares moms for what to expect during their hospital stay, and it serves as a way to normalize breastfeeding within our healthcare systems, communities, and families. In step 10 with postpartum education, we're having discharge classes at the hospital. That's one way some of our hospitals identified that we could provide support to them. And so those classes are helping to reinforce information that has already been provided by the hospital. And then it gives our WIC peer counselors a chance to initiate early support and encouragement. They also take that time to do referrals to local support systems, such as baby cafes, La Leche League, our Mississippi Breastfeeding Coalition, and our Mother's Milk Bank of Mississippi. And these are our next steps in the MOU. We are continuing to promote the MOU and hope to sign on those additional hospitals. We are also implementing evaluation measures for our MOU-related activities, and we're working to identify strategies to strengthen our referral system to ensure that we provide a continuum of care post-discharge. And I had to add this picture in. A friend of mine on a Sunday, this adorable picture pops up on my phone, and it's her granddaughter who is insisting on helping her mom pump. And so I thought this picture just really represents what our ultimate goal here in Mississippi, and that is to create an environment where breastfeeding is a normal part of life. Thank you very much.
Hello, this is Tawanda Logan Hurd. I'm a regional breastfeeding coordinator for the Mississippi State Department of Health with WIC as well. And today I'll be talking about actual partnership and practice with the baby cafes that we have established in the community. So the Baby Cafe, as some of you all may already know, is a free drop-in community-based breastfeeding support site. And it's following a proven model that offers a comfortable, inviting atmosphere, and we like to have it colorful and, you know, just inviting and cheerful. We provide information and uplifting messages displayed throughout our site. And the reason why we decided to start up a Baby Cafe is because WIC was the main resource in the community to provide breastfeeding information and support, but not everyone meets the criteria to qualify for WIC. Unlike Texas, you know, I wish we were utilizing those funds as well for our breastfeeding services. But all mothers and families need the opportunity to receive education and support throughout their prenatal and breastfeeding journey. So now we currently have 12 baby cafes in Mississippi, and our numbers are increasing. The first one was established in one of our counties in our sites called Greenville, Mississippi, and that's in that town, and it's located in the health department, and it's staffed by peer counselors and also volunteer staff, home visiting staff in the community volunteer their time as well. And our most recent one was established in a site in Mississippi. It's in Indianola, and it was opened in April of 2019 of this year. So our Baby Cafe goals, we want to encourage positive breastfeeding attitudes. So we want to be there to provide information to the moms, help them become knowledgeable of what to expect when they go into the hospital to deliver, and just help them to feel comfortable in an area where they're free to breastfeed. We demonstrate peer modeling because they see other moms coming in, being comfortable nursing their babies, talking about their experience and everything. So, you know, they're able to gain that information and that insight from other ones that they see. And they also receive education, and that is to help them, you know, breastfeed longer for their, you know, to increase our duration rates. Because we might have a high initiation rate, but our duration rates do drop off as the time goes on. So we bring them in, provide all kind of education to them to help them overcome any barriers that they might have concerns about, to help them have a positive experience. And we provide the knowledgeable solutions that they might encounter. We also provide them with referrals to various resources that can resolve any issues that they have. And it's facilitated in various ways. We might have an open discussion. We might have a certain topic that we're talking about, or we just might have groups to break out and talk about various things. So in our cafe, there are various services that are provided. And this is a list here. We do weight checks for the baby if the mom desires, or we actually let the mom do it herself. We provide assistance with latching position. We just provide that open space where they can socialize and receive education from knowledgeable experts. The lactation services that we provide are from skilled professionals. The physician referrals that I mentioned earlier, and we also collect data on the attendees. So this is a snapshot of our demographics from 2017. And you can see out of 58 attendees, we had these percentages down here at the bottom. 52% were pregnant moms, 20% were breastfeeding moms. So we see the majority of the ones that come are pregnant. And it's good that they can come and receive the information that we have to have a successful experience. And then we have, you see the list down here at the bottom as we go on. So these are our lessons learned, that baby cafes are necessary because families are not aware of what will take place when they go into the hospital. So we are there to teach them that. And we received our funding through the State Department of Health to help us continue on because we need the funds. We can't go on without them. We need training opportunities for others in the community so we can have that continued support and frequent communication so we can keep it going, keep the word out there. Thank you. Here's my contact information, my email address, and my phone number if you have any more questions. Thank you.
Tawanda and Kimberly, thank you so very much for that presentation. It was really, really great to hear how, as a community, more community-based agency, what you're doing to reach out to that birth facility setting to get them engaged, and even really to hear about some of the difficulties and how you did your work around by changing your point of contact in terms of that original reach out. And so, for everybody who's still out here on the attending the webinar, please push your questions into the Q&A pod. So it's right there at the bottom right-hand side of your screen. If you have questions for the presenters, put them there. While you're doing that, let me just tell you a little bit about things that you need to do in order to secure your continuing education. If you are looking for CERPs or CPEUs, you can go right there to this link. It's available to you so that you can get CERPs or CPEUs. You'll go to an evaluation quiz. If you're looking for other forms of continuing education, you can use the CDC, CE, TCEO instructions. So it's link number 3 within the resource pod in order to follow through to get that information. And before I do the question and answer, let me also just tell you that our very next webinar is going to take place on Wednesday, July 31st at 2 p.m. And at that webinar, we're going to be focusing mainly on community-to-community connections. And so we're excited, and so we have a few questions already for our presenters. And so the first question is actually for Rosemary. Rosemary, as you are connecting to your providers, the OBs and the pediatricians in the field, are most of those OBs and providers, are those the OBs who are catching babies at the hospital, and are those the pediatricians who are rounding at the hospital to visit newborns?
Some of them are. A lot of them are, we're connecting through Centering Pregnancy, and we get the referrals from them. And the pediatrician office, the one that we're active with, has the unique situation where they have a lactation consultant for their practice who actually does rounds in the hospital that we do rounds in. So we have that connection with her while we're in the hospital, and then if we go into her pediatrician, into her office.
Thank you so very much, Rosemary. The next question is actually for Valencia. The question is, how did you get clearance to bring peers and peer dads into the hospital? Did you encounter difficulties, and if so, how did you resolve?
I am so sorry. I don't have an answer for that because this program was up and running before I became the supervisor in this department. But I will say that we do have an MOU with WIC, and I assume that it was through that route. I'm not sure. I know that Danny, the manager of WIC, was listening to the webinar. I'm not sure if she's still available and able to answer that question, but it was in place long before I took on this role. I know that's not helpful. I'm sorry.
No, it's perfectly fine. And so what I heard, and I think that the good news is that this is a long partnership, and I think that very often, as Harumi talked about in the beginning of her presentation, laying the groundwork, that very often how you get a thing done is also very relationship-based, and partnerships are critical, and that that through this partnership you were able to put those things in place, and it preceded you. I will say that through NACCHO's former grantees, we did have people who put in place working relationships between hospitals and WIC, and it was also established through MOUs. And I think that one good example, and it was actually shown on Harumi's slide when she gave you some community examples, she talked about Broward County, and Broward County in Florida is one where they put a WIC peer counselor into a hospital that was working to become baby-friendly. And although there was a lot of supports in place, I think that and it's important, and we did a webinar featuring them, that it was kind of rocky at first because WIC and the hospital had different messaging around breastfeeding, and it was important to kind of get those things ironed out. And so I think that partnerships are relational. You do need to have them formalized through things like MOUs, and which is a memorandum of understanding. And I think that we had another grantee, and this is questions from Leslie Lytle, so Leslie, you can always reach back out to us. If we had another grantee in Detroit, Michigan, and it was not a WIC peer counselor, but they used a community-based peer counselor to put in place to round at the hospital at night. And those roundings started around 10 or 11 o'clock at night. And through that rounding, the peer counselor, who became later a CLC, was able to visit with moms during more of that dark time when there's not so many visitors and whatnot in place. And it actually was a lot of hospital red tape. It did not go easy, and it took them almost a year to kind of move that through an administrative bureaucratic process. And so I think that the answer is partnership, time, and effort. All right, it's 3:31 exactly, and so we don't have time for more questions. I want to again thank all of our presenters for being here with us. You did an amazing job. We got a lot of great information. Any other really great questions, please send them to us at breastfeeding@nacho.org, and we will try to follow up with our presenters to get you some further answers. Thanks again for your time, and enjoy the rest of your day.
Thank you.